Welcome to Neuro Stories, the podcast that highlights the people behind neuroscience at the Walton Centre. Together, we'll lift the lid on the complex worlds of neurology, neurosurgery, and everything in between, hearing fascinating tales of the incredible staff and services carried out in the hospital every day. Hello. Good morning.
I am Samantha Mills. I am a consultant neuroradiologist here at the Walton Centre.
Tell me about your world, Samantha. Tell me about what you do.
So I sit in an office with no windows and usually with the lights off, looking at pictures of people's brains and people's spines.
What an introduction. Whenever I walk through radiology, I do see a number of consultants with very low light. Why is that?
It makes the contrast better on the pictures, so we can pick out any abnormalities much more easily. It's just an easier way to see and identify pathology.
Right.
Because everything we look at is black and white and shades of grey. Rarely do we look at colour pictures, so it's much better if everything's black behind you and you don't want light reflecting on you. So some of my colleagues have windows, which is a bit of a nightmare, trying to get blackout blinds to block all the light out.
Of course. What does it mean to do what you do?
I guess when a patient pitches up to either a neurology or a neurosurgery clinic, they discuss their symptoms and then the neurologist and neurosurgeon sends them off for a scan, either of their brain or their spine. And then those images are sent electronically to the reporting workstation. We look at all those pictures. So we're looking for people's degenerative disc disease that might be pushing on their spinal cord, or looking at the brain to see if they have brain tumours or conditions such as multiple sclerosis or things like that. So we're looking for the pathology.
Right.
And we spend a lot of time just looking at the pictures.
But it's almost like maybe spot the difference.
Yeah, in some ways. Yeah. And the brain's great at that because you've got two hemispheres and we can just compare one side to the other.
Yeah.
Symmetry is always lovely. Radiology is full of symmetry, so you can compare other sides.
Yeah.
Occasionally diseases aren't great because they like to be symmetrical. Then both sides are the same.
Oh.
But it's just being aware of those things.
I can see you're looking at the moment at a spine, is it?
Yes, yeah, that's right. Yeah, so there's spine on there.
How important is it to have scans?
You're not going to have a surgeon operate on you with no scans, okay? They need to know exactly what they're looking at. So it's essential so they can, certainly for brain tumours and things like that, so they can plan their surgical approach. Surgical approach is everything for the neurosurgeon. Yeah. So if you lesion locate correctly and give them the pathways and the tracks and things, it really helps them determine how they're going to do their operation. And of course, for the spine, you want to know which level the disc's at because you don't want to operate on the wrong level. So imaging is integral to all the sort of surgical management. And for the neurologists, it can help us identify different diseases. So we're, looking for the multiple sclerosis, looking for other sort of inflammatory causes, looking for dementias and things like that, and sort of patterns of atrophy.
Wow.
It's mainly because they have a sort of anatomical lesion in there. So you're still spotting lesions and things like that. When people are having seizures, sometimes we can see the seizure activity on there because it changes the signal characteristics within the brain. And we help them with sort of the anatomical locations of where to put electrodes and things like that. So the electrode ones, the epilepsy surgery ones, we can see where the electrodes and check they're in the right place. Yeah. And things like that.
So you help build the roadmap for things like that?
Absolutely. Yeah, we are. Yeah.
For you personally then, how did you come to be a consultant radiologist?
So I was going to be a neurologist originally. That was my aim in life. And then I came here, 1999, very, very long time ago. And actually while I was here, I realised that the neuroradiologist had a lot to offer. There's nothing quite as nice as looking at a series of images of the brain. Brain's very, aesthetically appealing.
Yeah.
And it's great. You're probing inside the body and you're acting as a detective, trying to find the pathology. It's my inner Sherlock Holmes detective skills that I really like. So the imaging you've got now, and then you look through all the images they've had in the past and why they've had that. And sometimes, trying to add it all up together and figure out what that bigger picture is.
So you're a fan of problem solving?
Yeah, radiologists are definitely problem solvers. I think it's very methodical. It's not just one picture. We have a series of different images and it's an algorithmic approach. So you work your way down your algorithm. So it looks like this on T1, it looks like this on T2. Therefore, I'm going to look and see what it looks like. And you just follow that pathway down. And there's something very satisfying about that. Yeah. I like maths. I like Sudokus and, that kind of thing. It's that sort of thing.
That logic of it following almost like a flow chart of if it's not this, try this. If it's not that, try that. Do you find that having done it for a number of years now, you've developed like an instinct, or you've developed like almost like a sense of what's in front of you?
Yeah, I think all that experience, it's all hours under your belt, isn't it? And pattern recognition, it makes it a lot easier to quickly come to your diagnosis, because you're sort of filing through your memory bank. I've seen that before. That's what it is. Yes, that all makes sense. I sometimes put an analogy, it's a bit like aircraft recognition, because you're pattern recognizing. Some things are very similar, but you've got a few other caveats, trying to pick up the pictures with certain patterns look like that, add it together and come up with your diagnosis at the end.
Why were you going into medical school and neurology at the time?
When I was about 14, I was more interested in aeroplanes than medicine, but my mum was a nurse and my dad was an aircraft engineer, and actually healthcare and medicine itself, diagnosing and treating, was really appealing. And that's sort of why I kind of went down that pathway, I guess. And some of the science behind it, I was always fascinated with the body and disease, and if you can treat things and do things. And I'm a radiologist, I don't treat things, but it's that diagnosis. I really enjoy that diagnosis and that problem solving. It's
integral, isn't it? Even though you don't see patients, you are very involved in the patient care. You're showing the direction, really.
Yeah, I think the thing about radiology is great because we interact with everyone in the hospital. The neurologists, the neurosurgeons, the nurses come down here, the physios, we speak to neuro rehab. So you're interacting with all of the medical specialities throughout the whole of the hospital. You're not just disease specific. You can deal with everything.
Were there any moments then when you were a child that you saw it, that you thought, oh yeah, that's what I want to do?
I always wanted to do neuroscience. I knew I was going to sort of be involved in the brain sort of thing. I used to read books by Oliver Sacks when I was in sixth form, and I just loved that concept, that puzzle solving concept, which is why originally I thought I was going to be a neurologist. So when I went to university, I did take a year out and did an intercalated degree in neuroscience. I went to Manchester, which was really unusual at that time because most universities didn't offer a pure neuroscience degree. So that was great. And then when I came back in, I thought I really love neuroscience. I still want to do the brain stuff. So I've always wanted to be involved with the brain.
And so being here at the Walton Centre, tell me about what it's like to work here.
I love it. I've been here 10 years now. I was a consultant in another hospital before that, but it was like coming home because I've been here before. So I knew the place. It's so unique. I know a lot of neuroradiologists across the country, and we are so fortunate here. It's just pure neuroscience. Everything I report has been requested by a neurologist, a neurosurgeon, neuro rehab, and nothing else. So you've got a really good high quality of request and clinical questions coming in, which really makes my job a lot easier. And I really love having that kind of feeling part of the specialty, and that tertiary referral aspect of it is so nice. We're nice and compact. Everybody knows everyone. I've got a really nice bunch of colleagues around here, and the radiology department's quite small and compact. 8 diagnostic colleagues. And we've got a few interventional colleagues as well, but some of them are doing some diagnostic now as well. If you've got a question, you can just go knock on someone's door, and we have a very much sort of shared opinion sometimes on very complex scans. It's just a really friendly place to work.
And what does a day look like for you then?
I'll roll in the morning, probably check my emails, which normally have a load of scans to get opinions on from across the region, because not everywhere in the region doesn't have a neuroradiologist, so sometimes they want a little bit more expertise there. And then I will start reporting some scans usually.
Lights down.
Lights down.
Contrast up.
Contrast up. And just start reporting through the work list. It'll be any old mix of mainly MRs here. I've got 5 MR scanners and 1.5 CT scanner, because we share our CT scanner with someone else. So I'll start just working through the backlog of images. So it'll just give me a range of MR brains, MR heads, and there'll be old CT thrown in there, and then a few plain films as well, the fractures and things like that, and the spinal cord implants as well and things. But it's mainly MR that we do.
Going through those reports and those new images as much as possible until you call it a day.
I get interruptions. People come and knock on my door and ask for opinions, and sometimes we'll get called to the scanner to go and look at sequences and things like that. Later on today, we've got an intraoperative case, so I'll get called round to the IMRI scanner, and they'll be operating on the patient's brain tumour, and then while they're still under the anaesthetic, they'll wheel them into our intraoperative scanner, and then we'll have a little look at the imaging with the surgeon and see whether there's any left and whether they need to go back and take any more, whether there's any complications and things like that. And then they'll either go back and close up, or they'll go back and take some more out. So that's a little bit more involved. I leave my dark office and go to a slightly brighter room, squint like a...
That variety is unexpected, I think.
Yeah. And the other thing we do, sometimes we do a lot more admin work where we vet scans. So people put requests on and then we decide what the right imaging is. So someone might request a brain and whole spine, and you look at it and go, well, actually, brain and just a cervical and thoracic spine.
Okay.
We alter the sequences and just determine whether they need contrast or not. And it's still clinical work, as you're deciding the clinical management of the patients and arranging things like that. And then we offer a second opinion service for across the region. So if the radiologists or the clinicians outside of Walton feel they need a neuroradiology opinion, it comes here. So we give second opinions to those. And then, of course, there's all the MDT work. So that's the multidisciplinary team meeting work. And I do the neuro-oncology one of those. I split it with two of my other colleagues. We will get a list late on a Tuesday afternoon. So that'll probably come through about 4. And that'll be 5 or 6 pages of patients, all with brain tumours across the region, where we go through all of their images for the meeting on a Thursday, where we sit and discuss what's on the imaging, what the histology was if they've had an operation, for the surgeons, whether they're going to do an operation or not, and for the oncologists, patients have the surgery, and we've got the histology, what treatment options there are, whether they need any extra imaging or not, things like that.
The Tessa Jowell Brain Cancer Mission re-accredited the hospital alongside its partners Clatterbridge and the North Wales Cancer Centre as another centre of excellence.
Yes, yeah.
What does that mean to you and the team?
Well, it is always rewarding, isn't it, to know that your work is being done to a very high standard and that it's being recognised. And we do have an excellent reputation for neuro-oncology, the Walton Centre, and that's in all areas from neurosurgery to radiology and oncology as well. So I've previously been involved with the British Neuro-Oncology Society before and sat on their council before, and our expertise is still welcome. So I'm running a perfusion workshop for them at their annual conference in a few weeks' time. It's nice having that recognition. It makes you feel good that you're doing your job and you're doing it well.
What inspires you to do more?
I like imparting knowledge to other people. So I do teach a lot outside of the Walton Centre. I am also the chair of the British Society of Neuroradiologists academic committee, which promotes research in neuroradiology. So I am research active as well, although I am a full-time NHS clinician. I kind of try and squeeze a bit of research in on the side. So I do a lot of imaging analysis for that, which I guess is a bit unusual for radiologists. Not many radiologists are active in research. And that's because there is so much radiology and so many scans waiting reports that some people just can't face doing a bit of research as well.
Yeah.
I like it. It's a bit more of that detective work, isn't it? And curiosity. And you've got to do a bit of something else, I think. Otherwise, the day job can get a bit mind-numbing. Looking at scans all the time, you go home and your eyes ache. So you've got to have a little bit of variety in there.
That repetition.
And but I do like teaching. I like imparting that knowledge and sharing those things as well.
And what would you say are some of the challenges for you in your profession? So
at the moment, the huge problem with radiology is there aren't enough of us. We're scanning more and more patients. We are fortunate at Walton, we are not outsourcing at the moment. So we're not getting external people to come and report our scans. Whereas a lot of my colleagues across the country, their work is outsourced. But with that, you lose the relationship between the person who is requesting the imaging and the person who's reporting it. I really appreciate that understanding of what our clinicians are asking on the request card. So I know when Professor Jenkinson is asking me something, what he means.
Yeah.
But I don't know that of someone I've never met before. I find it really beneficial to have that, but it is a big challenge for radiology at the moment. There just aren't enough radiologists. Yeah. We always want a friend, don't we, to share the burden of the workload. And it's always very satisfying when you've trained someone, off they go and get a consultant job, even if it's a long way away. You feel you've trained them up. Some of it is about making sure you've got the resources. When I retire, which probably isn't actually that long away, I want to know someone's going to be there if I need someone to report a scan for me that's going to be well trained. I think that the worry at the moment though is just not enough radiologists, and we're scanning so many more, and some of the diseases now require a lot more imaging.
And is it a case of people just not being interested in this part of medicine?
You're limited on your they have expanded the training numbers over the few years, but you're limited on the space, because if you've only got, like I say, we're small here. So we have, at the moment, we've got 2 interventional neuroradiology fellows and 1 diagnostic neuroradiology fellow. And then we've got a couple of more junior fellows that rotate through. It'd be lovely to have more people, but there's not really enough space or enough of us to train them.
We'll do the quick fire round now.
Okay.
Are you prepared?
I think so.
What would you be if you weren't a radiologist?
Well, if I'd done medicine, I would have been a chest physician. I think. I don't know why. I like lungs as well. If I'd not done medicine, I think I would have been a mathematician.
Wow.
I love maths, yeah.
What's your biggest hobby?
I quite like sewing, knitting, cooking. For the sort of more outdoorsy stuff, sailing. We're just starting sailing again.
Favourite song?
Oh, that's tricky. Maybe Dignity by Deacon Blue.
Favourite book?
I read when I get a chance, which isn't that often. I like the Rebus novels.
Okay.
So crime drama, that's my detective side. The other thing I'm really into at the moment is the historical stuff. So there's a lot of ancient Greek feminist takes on Troy and all the Greek myths. So the last one I read was Clytemnestra, which was really good.
Favourite film?
So I have two. The Godfather. I do like The Godfather.
Classic.
And then Top Gun.
Okay, two ends of a spectrum then, I'd say.
Yeah.
Food you love?
Meze. Sort of Mediterranean food. Lots of bits of everything. Hummus, bread.
Little buffet.
Tabbouleh.
Beautiful.
Kibbe.
Food you hate?
Tripe. It looks like cotton wool.
Why would you?
Yes.
So easy to do wrong.
Yeah.
What's the best advice you've ever had?
If you want to achieve something, you can probably achieve it, but be aware it will take time. And then the other thing, one of my friends has always said, shy bairns don't get biscuits, which means if you don't ask, you don't get.
What's on your bucket list?
I'd like to see the Northern Lights in Norway.
Wonderful.
Seeing them from the back garden
Yeah.
the other week was great, but it wasn't cold enough.
And finally, something very few people know about you.
I got my pilot's license before I got my driver's license. I had a flying scholarship from the Air Cadets. They used to do those. It was an incentive to get you to join the Air Force. I didn't join the Air Force. And then I joined the University Air Squadron, and then I stopped flying because there just wasn't enough time to do medicine and fly.
How would you say radiology's changed over your career then? Has anything exciting changed it?
Certainly in brain tumour world, we have some newer sequences. When I first started radiology, perfusion imaging was hardly heard of, but now we do a lot more perfusion imaging for some things.
That?
So that is where we get colour pictures rather than just black and white. And you inject the dye very quickly and you take a series of images and then you can plot what the perfusion is like in the brain.
Right.
So it tells you what the blood volume is like, what the blood flow is like, and sort of how much it leaks out and things like that. So it gives us a little bit more idea of the physiology rather than just the anatomical structure with regard to tumours, which is great for deciding whether tumours are low grade or high grade and things like that. And then we have other sequences such as spectroscopy, which can show us the metabolic activity in there. In the future, there are sequences like that can tell us the genetic signature by just scanning the patient's brain. It's quite cool.
That's quite detailed.
Yeah.
Then.
You'll know spectroscopy from when you were at school and we did sort of chromatography, when you put an ink blot on the paper and it separates out. Yeah. We can do that with MR spectroscopy and look at different metabolites within the brain. So we can look at little different peaks in structure. Crazy. And one of those, we can look at a byproduct that you get with one of the genetic mutations. And that will tell us what type of tumour it is. But that's not here yet. But it's something that might be in the future on the horizon, things like that. So radiology, there are exciting things like that. And of course, you can't go out with a mention of AI. AI in radiology, not so much in neuroradiology, but in breast radiology is a huge help at the moment.
Really?
So it will just help highlight where areas are. Some hospitals are using AI with neuroradiology for like A&E CT scans, which can point to areas. And it's really an aid to the radiologist. It's not going to replace us, but it might make it easier and quicker for us to report things. Yeah. And it might have a role where we're comparing scans. You use the AI to tell us whether it's bigger or smaller. It's probably a bit more efficient at doing that than we are as radiologists.
What's the most rewarding part of your job, would you say? When you get home at the end of the day and you sit down and you're rubbing your eyes because they're tired, what's the thought that goes, yeah, I'll go back in tomorrow?
It's getting the diagnosis right. That's always very satisfying when you get the actual histology right on some things and they can get the right treatments. Differentiating lymphoma from a GBM or something like that is pretty important because their treatments are slightly different. Recognising when it's not a malignancy, when people have thought it is a malignancy, because that makes a huge difference to the patient, okay? Recognising when it's things like an abscess rather than a tumour again, because it makes a huge difference to the patient. It's those things that your recognition as a radiologist that alters the patient management are the satisfying things. Sometimes the diagnosis is worse than suspected, but if it gives them a few extra weeks, that's still a benefit.
Thanks for listening to Neuro Stories. You can listen to more episodes on Spotify and Apple Podcasts, and you can stay up to date with the latest news and events from the hospital on our social media channels, at the Walton Centre on Facebook and Instagram, and at Walton Centre on X. If you've got any feedback, email the communications team at wcft.communications@nhs.net. This podcast was recorded, edited and hosted by Sam Fleet from the Walton Centre's communications team.